us to actually talk and kind of review some of the concepts, because some of them may be just a tad bit more complex than what you're usually used to, or maybe it'll just be so simple you'll be asleep. In either case, hope you learned something today. So welcome to Wonderful Wednesday, Antiarrythmics, boring, complex, or just too difficult. And of course, in my words, that would be never is it just too difficult for us to have a good appreciation of what we're doing at the bedside and trying to understand it in the simplest way possible. So first, we start with something really straightforward, something we all know and we're all really comfortable with, and that is that the sinus node is the primary pacemaker of the heart, and that it fires normally at a rate of 60 to 100 times per minute. Now, how lovely is that? 60 to 100 is what the sinus node fires at. 60 to 100 is what your normal stroke volume is. You only have to remember those two numbers when we're talking about normal sinus and normal stroke volume. Sinus node depolarizes. It's a particular type of cell known as the pacemaker cell. And we're going to talk about that in a few minutes. And that cell group is under balanced control of the sympathetic system, which causes it to fire more rapidly, and the parasympathetic system, which causes it to fire more slowly. That impulse is then distributed via special highways. Those highways are the internodal pathways, which distribute the electrical current into the atria and then into both the right and left atria, and then is gathered in the AV junction. And the AV junction, or the AV bundle, is so unique and fantastic because it has the potential to slow the roll. Now, what that really means is that it slows down the rate of conduction of the impulse, and that is in order to allow time for the atria to contract and therefore empty itself of volume or blood that actually ultimately, of course, fills the ventricle. So the AV junction plays a really important part in maintaining this relationship, which is both electrical and mechanical. So remember, we're talking about electrical activation, but you cannot have mechanical response without electrical activation. So remember, sinus node fires around between 600 or 100 times a minute under balanced sympathetic and parasympathetic control. And once that impulse travels down the superhighways or the super pathways and is gathered in the AV junction, it's held there for a period of time to allow time for the atria to contract and ultimately fill the ventricles. That impulse then travels down into what's known as the common bundle of His and then splits. And it actually splits into three basic areas. The right bundle, which stays only its own bundle. There's just one right bundle. The left main bundle, which then bifurcates into the division of the left bundle, which goes around the back wall of the heart. That's known as the posterior fascicle. And the front division of the bundle, that's known as the anterior fascicle. Now, the reason you have two divisions on the left heart is that the left muscle is so much bigger. And in order to basically activate the complete ventricle almost at the same time, in really literally 0.08 seconds, you have to have more than one highway distributing the impulse. So that's why on the left side, you have these two bundles, posterior and anterior fascicle, anterior to the front wall, posterior to the back wall, while you only need one for the right ventricle, even though in this visual, the ventricular size looks the same. The right ventricular wall is very thin, it's very narrow, it doesn't require a lot of electrical activation in order to have its contraction. Now, it's really important to remember that you have three basic pacemaker groups: sinus node, AV junction, and the Purkinje fibers, which actually invaginate into the ventricles. All three of these groups actually have pacemaker potential. And that is incredibly and profoundly important, because if there's a failure of primary pacemaker sinus node, AV junction will take over. That's called a junctional escape. That's not a dysrhythmia. That is an escape from death. It's a life-saving property of this redundant profile of pacemakers. If you have failure of the sinus node and the AV junction, or there's failure of conduction between these two or between the AV junction and the ventricles, the Purkinje fibers will take over as the pacemaker of the heart. Now, it's really important to remember that we talk about sinus node formation, we talk about junctional escape, and we talk about ventricular escape. I'm only reminding you that these are the properties of our pacemaker cells: sinus node, AV junction, Purkinje fiber. So if one higher pacemaker fails, you are not without electrical depolarization. But all electrical depolarization is not equal. The desire is always to start the wave of depolarization at the top of the heart from the sinus node in order to instill depolarization, which then facilitates contraction. From the top of the heart down to the ventricles, where the ventricle initiation is from the bottom of the ventricles contracting upwards in order to push blood out of the AV junction. Whenever there's disruption in this normal process, sinus node, AV junction, bundles to Purkinje fibers, when there's an alteration, this is typically going to be called a dysrhythm. Today, we're really talking about interrupting dysrhythms, not life-saving dysrhythms. But just want to remind you, even though I know it's really simple and straightforward, it always helps for us to start from the same place, that the sinus node depolarization is not something you see on EKG. What you see on EKG is when the impulse travels through the atria. That's what gives you the P wave. That is atrial depolarization. Now, why is that important? Because we know it's from the sinus node if it's absolutely regular and it always looks the same, because it means the point of origin is always constant. When you have AFib, you're going to have multiple surfaces that are depolarizing in the atria, and therefore you don't really have a P wave. You have fib waves, and none of them look the same. When you have atrial flutter, you have one point of origin, but it does something called re-enter. So it starts in the atria, goes down through the junction, re-enters the atria down through the junction. It's called a circle re-entry or a circus re-entry, and that always looks the same as well. So when you fire from the sinus node, if the sinus node is firing regularly, the rate is regular, the appearance of the P wave is always the same, but the P wave is actually about the way current travels through the atria. And when we see abnormalities or differences in the P wave, it will always mean that there is an impulse originating from somewhere outside of the atria. Remember that little pause time? That's called the PR segment. We talk about the PR interval from the beginning of the P wave to the beginning of the QRS. Even if it's a Q wave, we call it the PR interval. But really what we're talking about here and what's really important to us is that PR segment, which is that little delay time that allows time for the atria to contract and fill the ventricle while delaying the impulse in the AV junction, which is fantastic and wonderful. And then that impulse passes into the ventricle, and that gives us our common visual that we commonly refer to as a QRS. Whether or not there's a Q, whether or not there's an S, or even whether or not there's an R, we always call it the QRS, and that's the impulse being distributed into the ventricles. And then we have another delay time. That delay time is the ST segment. And that delay time is really important because that delay time allows the time period for the ventricle to contract and eject the volume from it. So we care a lot about that delay time, but we never want the delay to be too long, because the current of repolarization of the ventricles, the repolarization in the atria we don't see, but the repolarization of the ventricle instills the T wave on our EKG. And this is a time of particular instability of the ventricle during this period. So we never want that T wave to be pushed out too long, elongating ST segment or prolonging what we call the QT period, because the longer away from the QRS the T wave is, the more likely it will bump into the next P wave. And if the next P wave arrives during, most particularly, the downside of the T wave, if the P wave arrives during the downside of the T wave, it can initiate a very problematic dysrhythmia, typically referred to as torsade de pointe. Torsade de pointe occurs because of an electrical impulse that hits on that very fragile time period of the T wave. So really important to appreciate when we talk about antidysrhythmics, it is in the patient's best interest to have a standard sinus node depolarization and atrial recruitment, that's your P wave, a standard PR segment, which delays the impulse in the AV junction, allowing time for the atria to contract, a standard distribution to the ventricle, which gives us our normal QRS, again, not necessarily having all three of those, and then a small delay time that allows for the ventricles to contract without any current flowing. And then current is actually changing and returning back to its normal current, and that would be called the T wave. And reminding ourselves that the QT interval, or typically what we do here at Grady and everywhere else, I'm quite sure, is the QT corrected, which is just corrected for the heart rate. We always are concerned about that, especially when we're giving antidysrhythmic agents, because we will frequently see a prolongation of this period as we make cells rest longer. We'll prolong that QT interval, which means the patient's at risk now for prodysrhythmia, and in particular, torsade de pointe. So very straightforward. Always want the sinus node in charge, want a normal delay in the AV junction, want to distribute equally to the right and left ventricle, want all the ventricular tissue to respond. I want a delay time there, that's the ST segment. And then I want to see a T wave that occurs within a normal time period. So there's little to no chance that the T wave will bump into the next electrical impulse, the next normal P wave, which is firing right on time. So these are really important concepts, because when we talk about antidysrhythmia, most importantly, we're going to change all of these things. We're going to change the P wave, we change the PR segment, we change the time it takes to move through the ventricle, either speeding it up or slowing it down. We promote more delay, and we prolong repolarization. That's what we're doing when we give antidysrhythmic agents, and that's why it's so important for us to appreciate. So it is important also to come back and say, what is an arrhythmia? So an arrhythmia, remember, arrhythm means no rhythm. So really, truly, dysrhythmia is the more appropriate term, but arrhythmia is what's seen in the popular press. It's what's in all your textbooks. It's what people teach you and talk about, and that's okay. I'm not really that worried. I just want you to appreciate arrhythmia means absence. Dysrhythmia means dysfunction or disturbance. And a dysrhythmia is a disturbance in your heart rate, in the rhythm, in the impulse generation, or in the conduction of those impulses that actually depolarize the membrane. So depolarization of the atria frees calcium for contraction. Depolarization in the ventricles frees ionized calcium for contraction. Really important to remember. All depolarization is about freeing ionized calcium for contraction. Now, you have to remember that. That's so incredibly important. When patients are hypocalcemic, they'll have an altered contraction. When you use calcium channel blockers, you can reduce the calcium availability for contraction, which means you're not only looking at the rhythm, but you're always going to look at your stroke volume or your ejection fraction in relationship to antidysrhythmic. I couldn't tell you any more strongly or passionately how important that is. It's not the dysrhythm that is life-threatening. It's the effect on the contraction. So when I have chaotic ventricular rhythm, VFib, I have no ventricular contraction. A really important concept for us to remember in the rationale of why we're so concerned about dysrhythmias, why we operate so quickly, why we replace contraction in these alterations by doing cardiac compression. and by really trying to assure the best cardiac compression you can, which from my point of view is humanly impossible. So I'm always grateful for mechanical contractile capabilities, because even though we all have big egos and we think we can do great CPR, we always wear out after about 20 seconds and we're not doing good contractile work. So remember that dysrhythm management is actually about trying to improve the contraction. Now, when we talk about antidysrhythmic agents, it's going to be really important to separate contraction from depolarization and repolarization. So antidysrhythmic agents are about the electrical impulses and stabilization, but I want you always to connect on the other end that those electrical impulses are what encourage the release of free ionized calcium to be used for myocardial contraction for both the atria and the ventricle. Okay, so a couple of different concepts that are probably just important for us to appreciate and understand. We're not going to delve that deeply in there because it's a complex topic. Arrhythmia is a complex topic. And there's one thing to say, memorize this. This is sinus tachy. Memorize that. That's sinus brady. But how do you apply that? How do you understand it? How do you appreciate what agent should be ordered for what dysrhythm so that you can try to restore your patient to a more normal function? So it is really important to remind ourselves that there are three basic issues that occur with dysrhythms. The symptom presentation is usually very complex, and the symptom presentation is what actually determines the rapidity and the type of therapy that you're going to apply. But arrhythmias typically come because you are forming impulses abnormally, and we'll talk about that in just a minute. You are conducting in a backwards direction from atria to ventricle and back to the atria. That is called a reentry or a circus reentry, or sometimes a combination of both. I have an abnormal impulse that fires, but it enters into an anomalous pathway. It's basically a pathway that exists between the atria and the ventricle and bypasses the delay mechanism of the AV junction. So it becomes a very rapid rhythm. Okay, so really, really important to remind ourselves why we are aggressive in treatment is when dysrhythms actually reduce stroke volume or cardiac output. Why they reduce it, there are different reasons. When the heart is beating too slow, you just don't have enough compensation with a more rapid heart rate to maintain your cardiac output. Remember, cardiac output is stroke volume times heart rate. So when the heart rate is really slow, you are asking the ventricle to be super efficient. But if you already have a problem with ejection fraction, you have a dysfunctional myocardium, then bradycardia is going to be a life-threatening dysrhythm for you. When the heart is beating too rapidly, there's not enough time for the ventricles to fill with volume. Because remember, systole is very short, diastole is long. Diastole in the ventricles is when the ventricles are filling. So when we're tachycardic, we don't have enough time to fill with appropriate volume. Okay. And then we talk about ineffective ventricular contraction. That means any impulse that forms from below the AV junction, instead of starting at the apex of the heart and contracting up to the base, which is where the leaving valves, pulmonic and aortic are, your ventricle may be contracting side to side or anywhere in the ventricular region. So you're going to lose a lot of efficiency of your ventricular contraction, not to mention that it's out of order with the atrial contraction. So you're going to have a significant limitation in ventricular ejection when you have ineffective ventricular contractions because of ventricular premature beats, VTAC, VFib, torsade, dew point, and any variation thereof. Now, it's important to remember that atrial fibrillation, which I think last Wednesday, I spent my whole time on talking about atrial fibrillation. Really, really important to remember that atrial fib, particularly in a critical patient, can be life-threatening because there's such a significant reduction in ventricular filling, which means stroke volume goes down, cardiac output goes down. And if you don't have compensatory capability, which you won't because you have atrial fib, you're going to have a 50%, 40 or 50% reduction in your cardiac output. And that may be life-threatening. And of course, the dysrhythms that are completely chaotic. Anything that's in fib means you have multiple impulses forming in the chamber, multiple impulses forming in the atria with atrial fib, multiple impulses forming in the ventricle with ventricular fib, and it's complete and utter chaos, completely ineffective, and an almost complete loss of contraction. So when I'm in AFib, I've lost my atrial contraction. When I'm on VFib, I have lost my ventricular contraction. The issue with AFib is that still some of the volume will move from atria to ventricle down a passive gradient, but nothing will move out of the ventricle in VFib. And everybody here is aware of that. You've all taken basic life support, basic EKG, advanced cardiac life support, but sometimes we forget that the concern is not just the rhythm, but the contractile response associated with it. Point in favor here to say, I could have a patient with VF on ECMO or a bi-impella with VF who has a great blood flow. And that's because we've taken away the requirement for contraction by doing ventricular flow device, either ECMO or Impella. Balloon pump doesn't fit into that category. But you can have a patient with VF, and as long as they have a right side and left side Impella, they can survive the VF. The VF is no longer life-threatening to them because we are bypassing their ventricles. Same thing with ECMO. So lots of times patients who are on ECMO or in VF or they're in asystole, and until we can restore their rhythm, of course, we can't wean them from ECMO, but we still maintain their blood flow. So really, really important for us to understand this concept and kind of integrate it into the way that we look at our patients and think about what's important. Okay, so now I'm going to make some Barbara's bits. That's what I call when I talk about something that is oversimplified, that isn't 100% reflective of every patient that you're ever going to have. But what I want you to remember is pacemaker cells have their own rules. But in general, cells that are supraventricular, so from AV junction and above, they are under sympathetic control, sympathetic and parasympathetic control. They are calcium channel dependent and potassium channel dependent. And that's really important because what that means is when I have supraventricular dysrhythms, sinus tachycardia, atrial tachycardia, multifocal atrial tachycardia, junctional tachycardia, atrial fib, and atrial flutter, I basically have three primary choices. I may try other things, but I'm going to anticipate for those patients, I'm going to anticipate that they're going to get sympatholytics. We're talking about really tachycardic dysrhythms right now. Sympatholytics, calcium channel antagonists, and or potassium channel antagonists. Okay? Critically and profoundly important. Supraventricular cells outside of the pacemaker tree, supraventricular cells under sympathetic control, calcium channel dependent, potassium channel dependent. So I'm going to use beta block. I'm going to use a calcium channel antagonist. That might not be my first choice, but something like diltiazem, probably not for rapamycin, which has a lot of other effects, but probably diltiazem. I'm going to use calcium channel antagonist, diltiazem, and potassium channel antagonist in general, amiodarone. Well, that's pretty straightforward. If the rhythm forms above the AV junction, I'm going to use sympathetic blocker, beta blocker, calcium channel blocker, diltiazem, potassium channel antagonist, amiodarone. Those are my basic first choices. There are many other agents I can use, but those are my basic first choices because atrial cells for depolarization are primarily calcium channel and potassium channel dependent. Now, remember, we're talking about electrical activation. All cells mechanically in the heart, all cells mechanically for contraction are calcium dependent. We're just talking right now about electrical depolarization. From the junction and below, really primarily talking about all the ventricular cells, again, not the pacemaker tree, which is the sinus node, AV junction, Purkinje fiber, but all of the other ventricular myocytes. So if I have PVCs, multifocal PVCs, bigeminal, trigeminal, 3-beat tachycardia, multifocal tachycardia, V-flutter, V-fib, my primary choices will be sodium channel antagonist, which will not be your first choice, potassium channel antagonist, which will be your first choice, and you can also choose beta blockers, although that is not your first choice nor your second choice and may not even be your third choice. But you want to be aware that sometimes physicians will order beta block therapy. It's not really a first or second choice. First choice typically is potassium channel antagonist, again, amiodarone. If the tissues are refractory, typically the agent that's going to be available to the majority of folks without a cardiologist ordering it would be lidocaine. But then there are other agents that will require cardiology intervention to order, like Pronestol or quinidine. Probably rarely would you see quinidine, but you do see procainamide now and other sodium channel agents. So again, what we want to remember, AV junction and above, sympathetic, calcium channel antagonist, potassium channel antagonist. AV junction and below, sodium channel antagonist, potassium channel antagonist. And those tissues are also sympathetic dependent, so we might use beta block therapy. Now I'm going to put torsade de pointe in a different category. Although it could be classified as a ventricular flutter or a ventricular fibrillation, what torsade de pointe really is an instability, aggressive instability of the cellular wall that typically has occurred because of a prolonged QT and an R on T phenomena. So it's a re-entry type of disorder in the ventricle. It's a circle disorder in the ventricle, and you see varying wavelengths of depolarization, which is why it looks like crepe paper. It's big, small, big, small, big, small, big, small, but it does not sustain ventricular contraction. Now, the cells are unstable. So historically, what we used to do was shorten the QT interval by giving patients something like isoprel, which shortened the QT interval. Today, what we do is try to stabilize the cellular wall, and we're going to do that with magnesium. And we're going to typically do 1 to 2 grams of magnesium and then repeat it. It's advocated up to 6 grams. That seems like a lot. And then you consider other kinds of cellular wall stabilization. You can use a pacemaker, or you can use amiodarone. Amiodarone is not the first drug, nor the second drug, nor the third drug of choice. That's going to be MAG, MAG, and MAG. And then you move to amiodarone. And torsade, it fits into this categorically very differently than the other ventricular dysrhythmias that we might see. So again, if I just make it as simple as possible, sinus node can only offer a sinus dysrhythm, like sinus bradycardia, sinus tachycardia, sinus arrhythmia. The atria actually is outside of your normal pacemaker track. So this is a dysrhythm that comes from the atria, not from the sinus node. And remember that the atria is calcium, potassium, and beta block dependent for tachydysrhythmias. So we're really going to think about, in those rhythms, tachydysrhythms, we're going to block beta, block calcium, block potassium if it's an atrial dysrhythm. Then we go into the AV junction. Now, the AV junction is kind of a mess. It's a wonderful mess. It's a beautiful mess. I always talk about how much I adore my husband, and he always reminds me of Pigpen on Charlie Brown, like the most lovable mess that ever lived. The AV junction is the most lovable mess of the electrical pathway in the heart, because in the AV junction, you have both slow channels, that's calcium and potassium dependent, and fast channels, that's sodium and potassium dependent. And there is an abundance of both in the AV junction. So the AV junction, frequently what we're going to see is if we have junctional tachycardias, we will most likely look at those junctional tachycardias. They're all going to be categorized as SVT because they're above the ventricles. But we'll say at the AV junction, what we might consider is we might use potassium channel antagonists, then move to a calcium channel antagonist, then move to a sodium channel antagonist, even while we're targeting the AV junction. So that one's a little bit harder to categorize and make really just separate. Remember, sinus node and atria, sympathetic, calcium, potassium. And I didn't mean to say the sinus node. Atrial cells, sympathetic, calcium, potassium. Junctional cells are both calcium and potassium or sodium and potassium, and it really depends on how the patient responds to your therapy, what you're going to choose. And now we go down into the ventricles. And again, outside of the pacemaker network, just out in the ventricular myocytes, ventricular cells are sodium and potassium dependent. So again, that right away helps you to understand your dysrhythmia and your anti-dysrhythmics. You're going to choose potassium, calcium, and beta block for above the junction. And below the junction, you're going to choose sodium, potassium, and beta block. So remember, we're talking about rapid rhythms. We're talking about block, 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 block. You don't want to be blocking if your rhythms are slow. You're only blocking when the rhythms are rapid. And we're going to use all those different types of blockers when we talk about dysrhythmia. Now, I want to remind you about the things you think about overall. You always think about dysrhythmia associated with cardiac ischemia. But remember, dysrhythms are associated with cardiac ischemia because your cells the myocells are profoundly oxygen dependent for their electrical and mechanical response. So any reduction in blood flow and the hemoglobin that's carrying oxygen, such as you see, of course, with an acute coronary syndrome, you actually are going to expect cardiac ischemia and cellular level hypoxia, which then will present to you with dysrhythm. But also, after reperfusion, after bypass surgery, we are distributing toxic metabolites that have accumulated in those areas that were hypoxic. We now redistribute them throughout the myocardium. They can actually precipitate post-perfusion dysrhythmias. Many people who work in CVICU will recall that patients come back from the cath lab after having opening their vessel and placing a stent, so doing a thrombectomy and placing a stent. What they often will see is those patients will have post-perfusion ventricular tachycardia or ventricular dysrhythmias, and the same kinds of things can be seen, although you see others as well, in patients post-cardiac surgery. So it's important to say initial response may be cardiac ischemia and hypoxia that promote dysrhythmias before reperfusion. Post-reperfusion, toxic metabolites distributed throughout the myocardium can also cause dysrhythmias, and we're going to do some good protection if we're seeing any dysrhythmias. Really important to remember that myocardial acidosis, so that'll be represented to you just by general system acidosis. Your bicarbonate base are down, which means your metabolic acid is up. Myocardial acidosis interrupts the framework of cellular content at the myocyte, and it actually potentiates very profound dysrhythmia disturbance. Not a big surprise to say electrolyte disturbance, because what are we talking about here? The primary three electrolytes. There are others involved as well, but the primary three: sodium, potassium, and calcium. So anytime we have electrolyte disturbances, we should always be aware that we're going to see cardiac disturbances. May not be dysrhythmia, maybe prolongation of the QT, maybe a prolongation of the PQRS. Just really depends on the electrolyte, and that's beyond what we're talking about here today. But I also want to make sure that you appreciate when you are at your bedside doing your very best to get your patient's blood pressure up and you're titrating up and up and up and up on catecholamines, epinephrine, norepinephrine, we really can create profound catecholamine toxicity at the myocardium. Catecholamine toxicity at the myocardium is seen by the naked eye as dysrhythmia, but internally, it is profoundly affecting the life of the myocyte. So I'm going to see dysrhythmia as the symptom here, but appreciate that I may actually be destroying functional myocardium. So I have to be very aware of this in my daily practice as a critical care nurse. Oh, I work in surgery trauma. None of my patients have a heart, right? Well, of course they do. And of course, these things really affect them, and they affect them very profoundly because we're very generous with catecholamines and with titration of neurotransmitters or catecholamines to try to resuscitate blood pressure without looking at those secondary effects of that hyperacute beta stimulation, which now is causing an increase in myocardial oxygen consumption, which now puts me at the risk from myocardial hypoxia. So as best you can, and it's not easy, try to prevent dysrhythmia. Try to be aware of metabolic acidosis. Try to be aware of cardiac ischemic events. Try to be aware of excessive catecholamine exposure. Even if we're doing the very best we can, we still are not going to be able to limit all dysrhythmias, but we don't want to propagate dysrhythmias if we can avoid that. So most common things that I think happen in a general ward, in a general critical care practice, is unmanaged metabolic acidosis. No, you're trying to manage it, but it's unmanaged, and excessive catecholamine exposure, basically catecholamine toxicity because of rapid and aggressive titration of vasopressors. So if you're having dysrhythmia, stop, try to determine the cause. Do an HS troponin to see if you have myocardial ischemia. Look at your total serum CO2 on your chemistry profile or your base deficit in pH on your arterial gas that you drew now. 4 hours ago wasn't meaningful. I need it now. My patient has dysrhythmia. I need it now. What they had yesterday, what they had 12 hours ago, what they had 5 hours ago is not meaningful. I need it now. And then look at your drips and consider that when you are 2 to 3 times your starting norepinephrine at 2, so when you're at 6 or above, that you may be inducing some level of catecholamine toxicity. When you're greater than 2 of epi, you may be inducing some level of catecholamine toxicity. So yes, of course, treat the dysrhythm, but try to determine what the cause is and what is within your ability to control. Not very much, by the way, because a lot of this is iatrogenic, idiopathic. We can't always understand it. So antiarrhythmics in a textbook, it's really interesting, but I use it to put me to sleep. So try it if you have insomnia. In the lecture, it's always confusing. It's always confusing. And when you're taking an exam, your CMC, your CSC, your CCRN, your PCCN, your CEN, you panic. Oh no, what agent am I supposed to use? So that's why I want to simplify it. From the junction and above, beta block, calcium channel block, potassium block. Junction and below, sodium block, potassium block, sympathetic block. Pretty straight and pretty important. Now I'm going to make it just a little bit more intense, but just a little bit more intense. At the walls of your cells, you have something called a threshold. The threshold is when you open up the gates for ions to come in and out of the cell. Okay, so don't make it more complicated. Just really listen to what I'm saying. Threshold means I'm going to open up channels, the gates, that allow ions into my cell, which change the electrical poles from relatively negative, meaning negative from the inside of the cell, to positive on the outside of the cell. Now, the sinus node and the AV junction and the Purkinje fibers are all really close to threshold. Threshold is when the cell is negative 60 inside the cell in relationship to outside the cell. And so that's what actually opens up the channels and allows sodium, potassium, calcium to move back and forth. That's what's really important. every other cell in the heart, every cell in the atria, every cell in the ventricle, every cell in the junction can actually reach threshold first. And I always remind you, he who reaches threshold first means they open the channels and they're in charge of depolarization. So our goal is to keep all of our myocells where they're supposed to be, and they're all supposed to be at -90. Sinus node, -60, AV junction, -70, Purkinje fibers, -80. Closest to threshold is the sinus node. That means it's easy for it to get to the place where it opens the channels. And these pacemaker cells are always slowly processing towards depolarization. Sodium goes into the cell, goes into the cell, goes into the cell. Threshold is reached. We open up and allow the other ions to come inside, calcium to come in. When calcium comes in, potassium has to go out. That's what repolarizes us. And then ultimately, calcium goes back out, and then we come back down to negative, and then sodium slowly goes in. And all that's telling you is he who opens up his gates first is going to be in charge of the heart. Pacemaker cells, SA node first, AV junction second, Purkinje fiber third, should always be in control. Other cells, every other cell in the cardiac structure can reach threshold. They gain control when there's issues with oxygenation, because you need a particular oxygen-powered pump to keep your cells at their negative base. And when ions are out of regulation, that also can put those cells at risk. So this is really important for us to appreciate and understand. All other cells should be far away from threshold. So when they're stable, they're all kept down here at about -90, and it's much harder for them to get to threshold, and they usually get depolarized by the current that was begun from the sinus node moving through the myocytes. Now, really only that I really want you to appreciate from this slide is that pacemaker cells are close to threshold. Come on in, sodium. And our other cells, which are not all sodium dependent, pacemaker cells are all sodium dependent, but all the other cells are not sodium dependent. The other cells are, come on in, calcium, come on in, potassium, come on in, sodium. When they reach that threshold and they invite those ions inside, they will become positively charged. And that's called depolarization. And they're going to share that news with everybody. He who reaches threshold first depolarizes the rest of the heart. He who reaches threshold first depolarizes the rest of the heart. Now, remember, there really are two chambers, atrial and ventricular, or two categories, atrial and ventricular. So frequently, when the ventricles are depolarizing, they're not going to depolarize the atria because it's just going to take too long for that to happen. Okay. So in order for us to appreciate and understand antidysrhythmics, we have to appreciate what cells are sodium dependent, what cells are affected profoundly by beta block, what cells are affected by potassium channel, that's everybody, calcium channel, that's atrial, and the miscellaneous ones that we're not covering today, things that are about AV block or about just paroxysmal supraventricular tachycardia, right? That's a really particular dysrhythmia that particularly gets adenosine applied. It's not all atrial dysrhythmia, it's not atrial flutter, etc. It's PSVT, which is a rapid start, rapid cessation, unknown where the impulse is forming, but we know it's from above the junction. So I'm not going to talk about those two. Sodium channel antagonists, primarily for ventricular dysrhythmia. Beta block, primarily for atrial and junctional dysrhythmia, but you might see it used for ventricular dysrhythmia. Potassium channel antagonist, dysrhythmias everywhere, atria or ventricle, doesn't matter. They all rely on potassium. Class 4, calcium channel blockers, those are really for atrial dysrhythmias. Isn't that easy? That seems really straightforward to me. Okay, so first I want to just talk a little bit about beta block really quickly and just remind you that in recent years we have beta block therapy that is cardioselective. Non-cardioselective agents are more prevalent. They're cheaper. Many of them have a long half-life, but because they're non-selective, they also affect your lung parenchyma and your conducting airways. So in general, we're going to choose cardioselective beta blocking agents for dysrhythmias that originate in the sinus node or in the atria, occasionally in the junction, but most of the time, sinus node and atria, and that would be most commonly metoprolol, atenolol, and bisoprolol. Now, if we look at metoprolol, you'll see that has a very short half-life. So when we're starting you're in the hospital, you're in the ICU, typically we're always going to give you metoprolol because it has a short half-life. And if it didn't work well, it's only 3 hours, whereas these other agents have a much longer acting consequence. And those are going to be the kinds of agents that we're going to send people home on because those are longer acting. And a lot of it is going to depend on what they can encourage financially. Okay, so again, I just want to remind you about, as we move to the other antidysrhythmic agents, I just want to remind you, this is your cell. Inside your cell, you have a lot of proteins with negative charge. Your potassium is at around 150 millimoles. Your calcium is 0.001 millimole. Sodium is 20. And that's the same really as the milli equivalent. So outside your cell, potassium is at 4. So inside the cell, you got a lot of potassium. Outside the cell, you have hardly any. You have a lot of calcium outside the cell, hardly any inside the cell. And you have sodium, a lot of sodium outside the cell. So in order for sodium and calcium to move into the cell, potassium will have to move out of the cell, okay? So all you're really understanding here is that inside the cell is negatively charged in relationship to the outside of the cell. It doesn't hold a negative charge, it's just less positive than the outside of the cell, and the equilibrants are higher outside the cell, and that sets up a potential for change. So remember, when we're talking about atrial cells, they are primarily calcium dependent. Calcium moves into the cell, and that promotes depolarization. In the ventricular cells, sodium moves into the cell, and that promotes depolarization. Atrial cells much more calcium dependent than ventricular cells, which are much more sodium dependent. And potassium channels actually affect very significantly that refractory period of time when the cell is stable and it can't be discharged and it's not going to accept anything else. And so we really like to use the potassium channel antagonist to kind of prolong this period of time where cells are resistant to another impulse. Now we're going to apply this based on a classification that's over 20 years old. And in current literature from the Journal of Cardiology or the American Journal of Clinical Cardiology, the AJCC, and in critical cardiology journals and in EP journals, there are many more classifications than this. We've uncovered so many other channels and so many other methodologies. But for us today, at the bedside today, what we have to appreciate are the 4 basic classes. Class 1, sodium channel, primarily ventricular. Class 2, beta-adrenergic block, primarily sinus and junctional, may be used for ventricular. Class 3, potassium channel, atrial and ventricular. And class 4, calcium channel, primarily atrial. Okay. We have to appreciate and understand that our pacemaker cells are going to be affected differently than all of our other cells. And that's why we talk about with sinus tachy, you're going to use a beta blocker. You're not going to use a calcium channel antagonist. Calcium channel antagonist can be used for sinus dysrhythms, but for tachycardia, what you want to do is limit beta stim. But for atrial dysrhythmia, you're going to use a potassium channel antagonist, which will make the cells more resistant to the abnormal electrical impulse, and a calcium channel antagonist, which will make the cells less likely to depolarize. Because when we slow the role of calcium, it's harder to depolarize. And when we slow the outflow of potassium, our cells stay more resistant to an abnormal electrical focus. Okay, so I'm just going to move through that. And I'm just going to say, here is the basic choice for dysrhythmias. And this is a basic category. Everybody isn't going to apply to this, and you are going to always be open to trying other agents when you see that patients are refractory. But if you have atrial extrasystole, you have atrial PACs, MATs, and your patient is symptomatic, he's short of breath, he feels really tired, he feels his heart beating rapidly, you don't give them anything if they're not symptomatic. But if they are symptomatic or if they feel disturbed, you're going to give beta block. PSVT, you got to terminate that paroxysmal circus reentry beat. So calcium channel antagonist, potassium channel antagonist, not going to work as your primary agent. Your primary agent will always be adenosine. If the patient fails 6-6-12, then you're going to move to a calcium channel antagonist or a beta blocker. At home, those patients will have to take a calcium channel antagonist and or a beta blocker, or a potassium channel antagonist with beta block properties. That's sotalol. But very important to remember, the rapid onset means that I need to basically chemically cardiovert. That's why we give adenosine. It stops everything, which allows time for the sinus node to take back over. So you really only do this with a reentry type of dysrhythmia, paroxysmal supraventricular tachycardia. I'm sure it's not AFib. I'm pretty sure it's not a flutter. It's not multifocal atrial tachycardia. It is really extremely rapid rate, and it had a rapid onset without any prodrome or pro-warning. I'm going to start with adenosine. And of course, that patient, of course, is likely to have very profound symptoms. Remember, adenosine is electric defibrillation, basically. It causes cessation of all rhythm to allow time for the sinus node to take back control. Atrial fib, obviously, very concerning for us in many, many ways. And if you came to the atrial fib discussion last week, really important to remember the first thing we're going to do is try to control the rhythm. And we control the rhythm with amiodarone, potassium channel antagonist. We can move to other forms of potassium channel antagonists outside of amiodarone. Those agents will require a cardiology consult and the cardiologist to order these agents. These agents are purely under cardiology control, and they can, except for amiodarone, they cannot be administered in the hospital without a cardiologist involvement. Those patients will actually go home for more, when they have more chronic ventricular rate control, they'll be using beta block therapy or calcium channel antagonists, okay? Really, really important. If your patient is an AFib and they're conducting at a rate of 200 or 210, because remember, AFib, the atria is fibrillating at a rate of 300 to 600 times a minute. You don't want the ventricles to be responding. But if the ventricles are responding at a rate of around 200, you can give IV esmolol, which will have a really rapid response, hopefully, or you can move to a calcium channel antagonist. Typically, verapamil is going to be more likely to be useful rather than cardizem, but either one is okay. And then, of course, amiodarone. And whenever you see that heart, that means you've got to have a cardiologist on board. Same thing with a flutter, cardioversion, choose radiofrequency ablation. We can give our patients verapamil or diltiazem or beta block therapy to slow down the ventricular conduction. And then we can use propafenone, that's known as Rhythmol. Again, very selected cases, very potent antidysrhythmic, must be given under cardiologist control, and it's not used very often. Some hospitals don't even have it on formulary. Okay, and we're going to control the ventricular rate, of course, with beta block therapy, calcium channel antagonists, and others. For Wolff-Parkinson-White, which I think is a little bit beyond us today, but Wolff-Parkinson-White, really, really important to remember. This is an anomalous pathway that connects the atria to the ventricle. And again, it's a circus reentry where we depolarize. We have a premature beat. It gets depolarized down that pathway, back up in a backwards direction through the junction, or you depolarize through the junction, goes back up through the anomalous pathway. This is really, really important. It's a very particular type of dysrhythmia, requires an electrophysiologist to actually diagnose it, and very particular therapeutic interventions. But you'll see for almost everything, you'll see amiodarone, 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 not here, amiodarone, and really important to appreciate that when I have atrial fib, when I have atrial flutter, not for paroxysmal supraventricular tachycardia, but for ventricular dysrhythmias as well, amiodarone is always the safe first choice. When you don't know what it is, you can always appreciate that all electrical depolarization has dependency on potassium efflux. So when you use potassium channel antagonism, you can treat atrial and ventricular cells. Potassium channel antagonism doesn't treat sinus node, AV junction, Purkinje fiber. Potassium channel antagonism is not the drug of choice for paroxysmal supraventricular tachycardia. Sometimes we don't know what it is, and sometimes we try adenosine, 6,6,12, but if you haven't responded to 12, you may choose to give 12 more. That may happen, but you got to be thinking about what's next. And what would be next would be amiodarone or calcium channel antagonist. Remember, it's called PSVT, so you know it's from above the ventricles. You know that it's going to have some responsiveness to either calcium channel antagonism or calcium channel block, potassium channel block, and beta block. So when in doubt, try all three. Okay, in the ventricles, we're going to use potassium channel antagonists, and generally we're not going to ever consider calcium channel antagonists. I see sometimes that probably less experienced physicians will start with amiodarone for ventricular dysrhythmia, and then they'll go to diltiazem, but that isn't really going to work on ventricular dysrhythmia. We're going to move from amiodarone to the one agent that you probably can order at the bedside without a cardiologist, and that would be lidocaine. So really important, sinus node, beta block, atrial dysrhythmias, calcium channel antagonist, potassium channel antagonist, and if it's PSVT, adenosine. Nodal dysrhythmias, beta block, potassium channel antagonist, sodium channel antagonist, and you can consider calcium channel antagonist. And if it's ventricular dysrhythmia, potassium or sodium channel antagonist. So always really important to just remember these agents. Okay, so you can just take a look here, looking at the classification of the dysrhythm and the types of agents we'll use. Class 1, sodium channel, ventricular, quinidine, pronestal, lidocaine, mexiletine, flecainide, propafenone, and the only one you generally can use without a cardiologist will be lidocaine. And that is second tier because you're always going to start with potassium channel antagonists, and that will be amiodarone. Every cell requires potassium for repolarization, and so you're going to use that potassium channel antagonist to delay the period of refractoriness before you can accept another impulse. Sotalol is the potassium channel antagonist and a beta blocker all rolled up in one. That requires a cardiologist. Okay, class 2 beta block, typically you're going to use metoprolol, but propranolol, esmolol, other agents can be used here for beta block. That's going to really primarily be about rate control, not rhythm control. You're just controlling the rate. You want the heart to slow down because it's so tachycardic. Okay, and then calcium channel antagonists, most particularly we use diltiazem today, but we can use verapamil. So that's a really important concept. Really helps us to appreciate and understand. And if you join with me next week, we're going to talk about the 5 most common antidysrhythmic agents we use in critical care today, what we as nurses should be doing to make sure that it's being administered correctly, to actually put the brakes on when it's no longer correct, and to actually understand what we should be observing and considering when we're giving those agents to our patients. So as you know, this is the end of our time. At the end of our time, I stop recording, but I do come back so we can have some conversation. I thank you very much for attending today. I really appreciate that you share your time with me and that you share your desire to do the very best you can for the patients that you care for. Hopefully you've learned something new today, and I'm going to say thank you so much and see you next week. Bye-bye for now.